Hello, everyone. Welcome to our Thursday webinar series. My name is Lourdes, and I am glad that you are with us here today for our webinar. As per usual, I just want to remind you all to please put any questions you might have regarding this webinar into our chat or the Q&A function in the Zoom setting, and then also to make sure that your questions are general in nature. I am happy to introduce our speakers for today. Dr. Javle is a professor in the Department of Gastrointestinal Medical Oncology, Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center. And Dr. Jean Fan is our Chief Medical Officer of Transthera Sciences. Thank you so much for being here today and sharing this information with us.
Thank you very much, Lourdes, for your very kind introduction. My name is Milind Javle. I'm from MD Anderson, and I'm going to talk about the next generation FGFR inhibitor for cholangiocarcinoma, Tinengotinib. I do want to mention that I am an investigator on this trial, and I am accruing patients on this trial. However, this is not a sponsored presentation, and I do not have any reimbursement for this role. May I have the next slide? So I'm going to discuss the mechanism of tinengotinib and the results from the clinical trial. So this is a novel agent that is being under development for about, I want to say, close to 5 years in our targeted therapy department. And based on signals that we noticed in cholangiocarcinoma, it is going into a pivotal study in this space. So you're familiar with cholangiocarcinoma, but for those who need the introduction, I would say that biliary cancers are divided into small duct cancers that are above the bifurcation, which is at the junction of the Y, because I'm not sure my pointer works. So above the Y junction are what we call small duct cancers, and below the Y are large duct cancers. The small duct cancers are also called intrahepatic cholangiocarcinoma, or ICCA, and below the bifurcation is extrahepatic cholangiocarcinoma, which is further subdivided into perihilar cholangiocarcinoma, which is like very close to the bifurcation, or PCCA, and distal cholangiocarcinoma, that is below the gallbladder, which is the third lowest slice here, which is the lower segment of the bile duct. So it's called distal cholangiocarcinoma. Next slide. I should mention on the previous slide that we make these differentiations because the genetics of these cancers differ depending on whether it's in the small bile duct, large bile duct, whether it's the hilum or in the distal bile duct. And there are treatment approaches also secondarily differ. Some of the risk factors of this cancer are listed here, and they may be related to fluke infection in Asia, hepatitis in many parts of the world like B and C, related to lifestyle issues such as a fatty liver, such as sometimes associated with high BMI or body weight, alcohol, substance abuse, and so on. But I have to say that most of the time when I see a typical patient in my clinic, none of these factors apply. But these are some of the known factors. May I have the next slide? So this is a treatment algorithm for cholangiocarcinoma. So it's a little crowded, and I apologize. Let me first start with local, which is at the left side here, and which is local is restricted to a segment of the liver or segment of the bile duct. Clearly, what we first try to do is surgery, if possible. If surgery is not possible because of a borderline situation, for instance, the size of the tumor or approximation to blood vessel, we give chemotherapy before surgery. That is called neoadjuvant chemotherapy. And the goal there is to hopefully cure the cancer, but after resection, then we give chemotherapy to prevent recurrence. If the tumor is liver limited, that is regional, that is, it's not resectable, but it's still localized to the liver, then we consider a variety of local therapies. And these local therapies include radiation, include Y90 radioembolization, ablation like microwave ablation. And what is not listed here is also histotripsy in selected number of patients. A small number of these liver-limited cholangiocarcinomas, whether they be perihilar or some cases intrahepatic, can be considered for liver transplantation. The discussion we are going to have today is the systemic therapy, which is the circle that you see on the right, which is restricted for patients for unresectable disease. And these patients are treated with systemic chemotherapy or chemoimmunotherapy. Over the last 2 years, since the Topaz 1 and the Keynote 966 trials, these patients get chemo plus immunotherapy. And after that treatment stops working, or if the tumor progresses, then we consider targeted therapy, depending on the genetic alteration, the genetic underpinnings of the cancer. For instance, FGFR inhibitors, BRAF inhibitors, IDH1 inhibitors, and so on. We're going to talk about FGFR inhibition today. And of course, on the right is clinical trials, which is always a valid option, no matter what stage. So we try to get every patient no matter what stage, surgical or non-surgical, to assess if clinical trial is indeed a possibility. Can I have the next slide? So we have so far 2 drugs that are FDA approved for the management of cholangiocarcinoma with FGFR fusion. Sorry, this doesn't project very well. But the first drug to be ever approved in cholangiocarcinoma was pemigatinib. And pemigatinib is a FGFR inhibitor. It targets FGFR 1 to 3 receptors, but it was specifically approved for the management of FGFR2 fusion, where the FGFR2 gene fuses with another gene, and as secondary to and as a result of that, leads to tumor progression. So pemigatinib specifically targets this, and then as you can see in this waterfall plot, a large number. So when you see these bars going down below the horizontal, these are responses, that is tumor shrinkages or tumor responses. And majority of these patients, had some sort of improvement. So the response rate, that is the tumor shrinkage rate that occurs more than 30% tumor shrinkage, that occurred in 35% of these patients. But tumor control, that is, in how many of these patients was the tumor, even if it didn't respond, even if it didn't shrink down, it stabilized. So if you calculate all of them, then the total number was about 82%. So I've had many patients on this therapy. Patients have done very well, including some patients who are on today on this call. So certainly a valid option for this cancer. Next slide. And the second agent to be approved after this was futibatinib. Futibatinib is another FGFR inhibitor. We call that a covalent inhibitor, like the pemigatinib is a reversible inhibitor. When it inhibits the FGFR fusion, that effect can be reversed with time. This is an irreversible, so it's called a covalent inhibitor. And it had a little higher response rate, that is 43%. Disease control rate was similar, about 85%. And as you can see again in this graphic, majority of the patients improved, where you see the tumor size decreasing with time in the vast majority. This occurs in both these drugs at the expense of some toxicity. For instance, nail changes, hand-foot syndrome. A small number of patients can get eye changes, asymptomatic retinal pigment detachment, which is reversible most of the time. Some people can get diarrhea, arthralgia, body aches. But for the most part, patients seem to tolerate these therapies well. Next slide. So the question is, what do we do when these drugs stop working? Now, there are some people in whom these drugs work for a very long time, sometimes even years. But for the vast majority, it's usually 6 to 8 months. And then often we see disease progression. Tinengotinib is a drug being developed specifically for those patients. So this is a FG. So on the left, you see the binding action of the first generation FGFR inhibitors, where they reach into the deep pocket. You see there is an ATP pocket, which is a binding site. It reaches into the pocket, and mutations in that gene can affect this potency, can affect the binding. So you see a red sign over there, which is, I'm not sure the pointer works, Lourdes, but in the middle graphic, you see a little red dot, which is a graphic of a mutation. So when that gene mutates, then the binding no longer occurs. Tinengotinib is a unique mechanism of action where it actually does not bind to the deep pocket, as you see on the right in blue. It binds with a high affinity, and it binds structurally away from the inner pocket, such that if the mutation forms in the figure on the extreme right, the red spot, even if the mutation forms, the binding occurs further away. So it's less affected by these mutations. So this is again represented here. It targets the FGFR binding away from the inner pocket. So the inner pocket is represented here, and then you have in the circle this binding site for tinengotinib, and it binds with an active conformation of FGFR with high affinity with the 3H bond, and therefore it overcomes this mechanism of resistance. How do we know that for sure? Well, we can know by checking models like preclinical models like cell lines or such in FGFR altered cholangio that have these mutations. And that's what I'll show in the next slide. Here, this complicated table on the top, you see the list of mutations. So V564F or V564I, N549K. I've been asked by patients, what do these represent? What is this V564F, etc.? So it means that on the particular position, like of the FGFR2 molecule, you have the amino acid valine, which is V at position number 564, it is replaced by another amino acid with the acronym F. So it's basically different. It's a way for scientists to know at what position did the mutation occur and what happened as a result. So you can see the drugs being represented on the left. That is, you have tinengotinib, pemigatinib, infigratinib, furibatinib, and Relay 4008, which is another very exciting new drug being developed for FGFR altered cholangio for previously untreated. So the red boxes demonstrate that in the presence of that particular mutation, you won't have that drug won't work. For instance, the gatekeeper mutation, the gatekeeper because it stops the binding action of the drug against the ATP molecule. So it sort of doesn't enter the gate, as was demonstrated earlier. In the presence of V564, pemigatinib no longer works, and that's why you see a red sign. Similarly, in case of furibatinib, in the presence of next V564I, furibatinib does not work. Excuse me for a second.
Just want to let our viewers know that Dr. Javle is actually at a conference at the moment, so there might be a little bit of background noise, but he will be right back, so hang tight with us. And just a friendly reminder, if questions come up, please put them into the Q&A or the chat. Either one of those would be perfect. And to please make them general in nature, as general as possible, please, because you cannot answer specific questions.
Thank you very much, Lourdes. My apologies to the audience. I'm at a meeting and I'm trying to find a quiet spot. But anyway, this is what is reflected with tinengotinib, the top row, which shows that these resistant mutations can be targeted with tinengotinib. That's why you see all the green boxes. And that is sort of the rationale why this may be effective in patients who have acquired resistance, that is resistance to after the tumor responded previously. Next slide, please. So these are graphics to show in vivo activity, that is activity in mice. PDX model is when a piece of the tumor is injected under the skin, and after it grows, we treat it with different drugs. So as you see on the left, you see intrahepatic cholangiocarcinoma with this FGFR fusion. Tinengotinib is the pink line at the bottom, so the tumor didn't grow in most of these models as compared with other drugs, that is, which were resistant. So it doesn't show you a lot more than what the previous slide showed, except that it was validated in vitro, that is in cell lines, as well as in vivo, that is in a mouse model. Next slide, please. So this drug has been investigated now in close to 100 patients with cholangiocarcinoma at different stages. I mean, they're all advanced disease, but in a couple of different trials. So there were almost 100 patients. These are the demographics, about 60. One was the average age. More patients were female, which is unfortunately the demographic of this cancer. More patients were more likely to be Caucasian than Asian, which is also what happens with which typically seen with this fusion. Patients had a good performance status. 40% of them had FGFR fusion or rearrangement, that is when the gene is fused to another. 31% had a mutation, which is, people refer to all of this as mutation colloquially, but it's actually different. Fusion is when one gene joins to another. Mutation is one base pair is replaced in the DNA with another. So 30% for mutations, there is no accepted therapy. There is no approved therapy. So in this case, there were about 30% of patients with mutation and other abnormalities. Most of these patients had previous lines of treatment. They definitely had one, but several had 2 or 3 prior lines of therapy. And many of them had received many different drugs. As you see on the bottom row, they received pemigatinib, infigratinib, relay drug, many other drugs that have been in development. Patients had been treated before. Now, these patients were treated in phase 1 trial, that is in dose escalation trial, as well as phase 2 trial, where the dose was noted and then it was administered to a group of patients in different cohorts, as we'll see in the subsequent slides. Next slide, please. So this was for all cholangiocarcinoma patients. Now, remember, most of these patients had fusions. Many of these patients had prior treatment with FGFR inhibitors. And you see a very nice waterfall plot with a response rate of 30%, where it shrank more than 30% volume. But the disease control rate, when patients either experienced stability or improvement, was in the vast majority. Over 93% of patients showed some benefit. Next slide. So this is the duration of treatment. This is called a Schwimmer plot, which shows how long did the patients get treated. So the duration of treatment is on the x-axis. Some patients have got treated for, many weeks. I mean, over 72 weeks. So this drug has not been around for that long, but, over a year and a half. And there were some which are shorter. But the median progression-free survival, that is time for progression, was 6 months, which was, again, these patients had received prior FGFR inhibitors for the most part. Next slide. So these are the treatment-related side effects. So this drug has different types of side effects than other FGFR inhibitors, where you're used to seeing high phosphate levels. You're used to seeing hand-foot syndrome and nail toxicities. You can see retinal pigment epithelial detachment. Those toxicities are actually quite uncommon with this drug. What we are more likely to see is hypertension, high blood pressure. So because it inhibits an activity of VEGF, that is prevention of cancer spread through blood vessels. It is also associated with some other toxicities like mouth sores, occasional diarrhea. You do see hand-foot syndrome, but to a lesser extent, and some nausea and fatigue. These are some of the most common side effects, and it can lead to dose interruption or modification, as you see on the right, for up to sometimes 40%, 50% of patients with time. Next slide. So these are the data from phase 2 trials. So let me explain the different cohorts. The second column is cohort A, which is primary refractory. That is patients who got, say, a prior FGFR inhibitor, and that never worked. Like it didn't really shrink tumor at all. And cohort, that is the first cohort, A, that is A1. The next one, that is FGFR relapsed, that is patients who had received, say, a prior inhibitor like, say, pemigatinib or futibatinib. And it had worked for some time, but then it progressed afterwards. Cohort B is other FGFR alterations like mutations, not fusion. And cohort C is like with no FGFR alteration where patients did not have any alteration in the FGFR pathway at all. So majority of the patients, as you see, had stage 3 or 4. And in the middle, you'll see number of prior regimens. Most of these patients had received, 3 or prior lines of therapy. So this was patients who were extensively pretreated. And then FGFR mutations were seen as well, as you see in the bottom. V564, which is typically mutations that don't respond to targeted therapy. Next slide. So this is the overall survival that is seen in the FGFR altered cohort. So cohort A, which is again the blue line, which is patients whose tumors never really shrank down. Cohort B, that is for mutations, and cohort C is the FGFR wild type or no FGFR alteration. So both cohort A and B, that is people who had received prior FGFR therapy, had a pretty good overall survival. In cohort A, it was 18 months. Cohort B, during the time of observation, it wasn't reached. So hopefully long. But both groups with prior FGFR treatment seem to do fairly well. Next slide. So these are the biomarker studies. So these studies, what kind of associated mutation, like besides every tumor will have more than FGFR fusion. So what other mutation in conjunction to the FGFR fusion would affect the outcome? So we noted that, interestingly, MEDI12 gene changes, they had a better prognosis. Patients, figure A, that blue flat line, showed that these patients with this mutation actually did very well for a very long time. Patients, on the other hand, patients with ARID1A or MET fusion, gene alterations, they had disease control without progression. And other mutations, for instance, in figure D, they were associated with a worse prognosis. So I think this is a path that is still evolving. But through these studies, we will find out, besides the FGFR fusion, what other mutations can impact the overall outcome. Next slide. So to summarize, I would say that tinengotinib is a next generation FGFR inhibitor, which is being developed in the FGFR refractory space. That is when this treatment is no longer effective. The first FGFR inhibitor is not effective, and typically a third-line therapy. So for instance, patient may have got gemcis and durvalumab, then got pemi or furibatinib, and then would be considered for a trial with this agent. It's being developed in this space. Next point. And it is well tolerated. The side effects were manageable. There is a learning curve. The physicians have to be comfortable managing hypertension and other toxicities listed. Next, please. Yeah. And there is a phase 3 trial that is ongoing. And this trial will evaluate tinengotinib versus physician's choice of chemotherapy in patients with FGFR altered tumors and FGFR inhibitor refractory cholangiocarcinoma. So patients who have received prior chemotherapy and have received prior FGFR inhibition. Currently, the only standard of care at this point would be chemotherapy, such as FOLFOX or FOLFIRI. So this trial will evaluate tinengotinib versus chemotherapy, because chemotherapy is also effective, to evaluate whether tinengotinib is better than systemic chemotherapy or not. So I'm going to turn to Dr. Fan, who will educate you about the trial, the phase 3 ongoing trial. I also want to point out that the phase 2 results and the phase 1 results are very promising, but they are based on relatively small numbers. So we have to now expand this experience and really learn about the effectiveness of the drug. And that's why the phase 3 trial is essential. Over to you, Dr. Fan.
Thank you very much, Dr. Javli, for the overview of the mode of action and also clinical data. Now, I would like to share an important phase 3 clinical trial we're currently conducting for patients with FGFR altered cholangiocarcinoma, a rare but aggressive cancer. This is the full title of the study. A phase 3 randomized controlled global multi-center study to evaluate the efficacy and safety of oral tenogrtinib versus physician's choice in patients with FGFR altered chemotherapy and FGFR inhibitor refractory or relapsed cholangiocarcinoma. First of all, I'd like to introduce the rationale of the phase 3 study. As we know, FGFR gene alterations account for 15% of iCCA. The first generation of FGFR inhibitors as second-line treatment have improved the survival of patients with FGFR altered CCA. However, many patients eventually develop a disease progression within 5 to 7 months due to the acquired resistance to the second-line treatment of FGFR inhibitors, which was attributed to kinase mutations. There is no established standard of care after failure of FGFR inhibitor therapy. The prognosis was poor after the FGFR inhibitor therapy in CCA patients who received chemotherapy or target therapy. The median PFS was 2.1 months and with overall survival about 6 months. Tinengotinib demonstrated a unique mode of action to overcome the acquired resistance by targeting FGFR2 kinase mutations in our preclinical studies. And also, Dr. Javli just shared the encouraging clinical phase 1, phase 2 data with tinengotinib as third-line therapy in FGFR altered CCA patients strongly support further evaluation of efficacy and safety in a phase 3 study. This open label phase 3 study is focused on the third-line treatment of the FGFR altered cholangiocarcinoma. And the study has experimental arm, which includes tinengotinib tablet, 10 milligram or 8 milligram, oral daily in part A to select the optimal dose, then proceeding with the selected dosage in part B. Control arm is physician's choice with chemotherapy, which is what patients would usually receive at this stage. Patients will continue to receive steady treatment until confirmed disease progression, intolerable toxicity, withdrawal of consent, or termination of study by sponsor, whichever occurs first. And this is the study design schema. As shown, the total recruitment is about 200 patients for this phase 3 study. The eligible patients will be randomized in 2 to 1 for part A to receive tinengotinib 10 milligram or tinengotinib 8 milligram or physician's choice. The primary endpoint for part A is designed to assess the safety to evaluate the tolerability of the 10 milligram or versus 8 milligram tinengotinib. And the secondary endpoints are ORR, which is to measure tumor shrinkage, and also duration of response and PK. So this determination will be made by the IDMC, and we have already had the IDMC meeting for this part A. And the part B, tinengotinib selected dose, and patients will be randomized in 2-to-1 to receive selected tinengotinib dose and versus physician's choice. And the primary endpoint is PFS, which is to measure how long patients are alive without the worsening disease. And the secondary endpoints include overall survival and the objective response rate to measure the tumor shrinkage, duration of response, and also how patients feel and how patients functioning. So for the quality of life and also patients' side effects, that's also we want to learn from this study, and PK as well. Currently, our first patient in occurred in December 2023, and our IDMC meeting was held in the first quarter this year. So now we are open for the Part B enrollment. And we targeted last patient in October this year. For the physicians or patients, if you want to join this clinical trial, please feel free to contact us. We have all our information in the clinicaltrial.gov, and I will introduce later. So this is the patient's eligibility criteria. For key inclusion criteria, patients must be aged above 18 years old, and patient must have histologically or cytologically confirmed cholangiocarcinoma, adenocarcinoma of biliary origin with unresectable or metastatic disease. And patients also must have documented FGFR2 fusion rearrangement. This is one type of the FGFR alterations. And the ECOG status performance of 0-1. So ECOG performance is to measure a person's performance status. Basically, 0 means the patient is fully active. And also the 1 is patients can active but cannot do the heavy work. So this is other metrics to measure the performance daily in a daily basis. Next is patients have received at least one line of prior chemotherapy and exactly one FGFR inhibitor, for example, pemigatinib, infigratinib, or futibatinib. So those are the 3 FGFR inhibitors patients received in the prior treatments. The last one is patients must have at least one measurable lesion defined by RECIST 1.1 because this study primary endpoint is progression-free disease. We have to measure the patient's tumor shrinkage and the progression. So that's we must have patients with the measurable disease. And the key exclusion criteria, if patients receive the prior 2 or more than 2 FGFR inhibitors, patients will be excluded from this study. And if patients receive both chemo, FOLFOX, or FOLFIRI, and patients also will be excluded from this study. But I want to mention this is for the treatment of cholangiocarcinoma, not for other tumor types. And the third is patients with uncontrolled hypertension, because one of the most frequently toxicity for this drug-related AE is hypertension. So we would ask patients must have controlled hypertension. Controlled, that means patients' blood pressure must be lower than 150 mmHg and also 90 mmHg for the diastolic. But this can be under hypertension medication management. Patients with active brain, also CNS metastasis within 4 weeks will be excluded from the study. But if patients had steroid controlled metastasis for 14 days before the treatment and is stable and also without escalation of the steroid dosage, so these patients will be eligible for the study. The last one, patients with AE greater than grade 2 from prior therapy, but this has to be excluded patients with grade 2 alopecia and fatigue, asthenia, and also a neuropsy from the tremor. So protocol has the more detailed information for those. And this is the clinical size of this phase 3 study, include Europe and also UK and Taiwan, South Korea, and also US. As you can see, we have right now over 20 sites in the US. If your location is close to our sites, or you are from another far away, we always can help for chance for you to the sites nearby you. So phase 3 study status now is active recruiting, and this is our clinical trial. The NCT numbers you can use to search the detailed information, and also EU CTR numbers. And also we have opened just in 84 sites across US, UK, Europe, 8 Europe countries listed here, and also Asia in South Korea and Taiwan. We do have patients even from another country, for example, in Russia, and we also help fund the nearby the sites in Europe, either in Poland, in Spain. So those are also possible if you are interested in participating our clinical trial. And this phase 3 lead PI is Dr. Javli at MD Anderson. Thank you, Dr. Javli. Dr. Javli had helped this drug development from phase 1, phase 2 to phase 3. Thank you very much.
Thank you very much, Dr. Fan. I think I can speak on behalf of all of us. We look forward to encouraging, new drugs and new developments. So hopefully this will be another step in the path for the patients. Now I'm going to try to answer the questions that have been chatted in.
Okay, one more question. Just two slides. I will finish. So this is just to show how you got the information in clinicaltrial.gov. Just to the examples, you put the number, NCT number in there. You can find all the detailed information, also the contact information for each site. And so those are the final slide of my presentation for summary. The phase 3 study, Tinengotinib versus the physician's choice as third-line treatment for FGFR altered cholangiocarcinoma is in recruiting. And we started in December 2023, and primary completion estimated in May 2026. Total enrollment is 200 patients. And next is the web link for the detailed clinical trial information. Thank you. So we are happy to take in any questions from online.
Thank you, Dr. Fan. Thank you, Dr. Javle. I know there was a couple of questions that came in, and I think you were trying to answer about the PIK3CA mutations and whether it limits the inhibitor effectiveness. I don't know if you've experienced this with Tinengotinib as well.
Yes, I'll try. Thank you very much, Lourdes. I will try to answer this question. Jacqueline, you're absolutely right. There is some thought that PIK3CA, but we don't know for sure. And at least the data that we have so far on the phase 3, on the phase 2 study, this was not one of the mutations that predicted a worse outcome. But so hopefully this will work even with that mutation. But I have to tell you this, we don't know enough to tell you any definite in that regard. Now, in terms of Melissa, is the drug available in Canada? I'm going to ask Dr. Fan if she can talk a little bit about the compassionate use program with this drug.
Yeah, we do have the compassionate use, which called also single patient IND program. If you are interested, you can contact our senior manager, Katie, who is online as well, for the compassionate use and for the detailed process, how to engage with the regulatory and to get approval, and we can help.
So, Melissa, this program requires the physician who's taking care of you to submit a request, get an IRB approval, the Research Bureau approval from their institution, and perform some regulatory paperwork. So it's not impossible. It does take some time, and our goal here is to make this drug available for anyone who may potentially benefit. I also want to say that the other option is that depending on where you are in Canada, if you have a location close by in the States, that would be an option to get onto the trial too. So, Jacqueline, is the drug available in Europe within the next year? So I think Dr. Fan mentioned that the study is open in sites in Europe. Is that right, Dr. Fan?
Yeah, correct. 8 countries in Europe.
Right. So the best way, Jacqueline, is to try to get this, to look up those sites on clinicaltrials.gov. And Katie is very nice. She will help you, where the site may be closer to you. And so that hopefully that may be an opportunity there. Christine, you have a very interesting question that if the progression-free survival is 6 months and the overall survival is 18 months, how is that possible? Well, I mean, it's true that the FGFR altered cholangiocarcinoma intrinsically tends to be a little bit less aggressive than the non-FGFR altered cholangio. That is, cholangiocarcinoma, as we all recognize, is a difficult disease, but those with FGFR alterations tend to have a better prognosis. So these patients, some of these patients went on, a lot of these patients were treated at Anderson. And so we believe not just in this therapy, but like many other cancer centers, like radiation therapy, like other treatments that might have also impacted on the outcome. But yes, there are some drugs, and I indeed don't know if Tinengotinib is that, where they may work for a certain amount of time, but their long-term impact on survival is much beyond. And if that's the case, I don't know with Tinengotinib, we'll find out. But certainly the overall survival is encouraging, that it seems quite long. Now, in terms of, I think...
There was a question about crossover arm for patients if they are randomized into the physician's choice, but then there's disease progression. Is that a possibility?
Yes. So, Jeff, I mean, this is what we would like to do. Unfortunately, this is not what regulatory authorities around the world allow us to do. We have to have, currently, there's no large evidence to say that Tinengotinib is better than chemotherapy in the second or third line setting. So it is possible that the chemotherapy may also give adequate benefit. And I also tell patients, so in this trial, there is no crossover. But there are other opportunities. I work in this field for many years, and so do many other of my colleagues. There are other FGFR trials that the patient can get onto, if not this for this one. But this trial, the way it is designed, it does not allow crossover. And that's really for regulatory purpose, because we are trying to get this drug approved as soon as we can, hopefully with a positive signal. And for that, we have to produce this sort of data to the regulatory people.
Correct. The crossover will impact on the OS analysis, which is the overall survival. And overall survival as a key secondary endpoint has been required by FDA to be successful in order to showing the positive study of this study. So that's why we want to keep the without crossover and eliminate the bias of the data readout and to achieve our goal.
So, Jeff and Christine, I would let Dr. Fan answer the next 2 questions. Lourdes, would you mind reading the next 2 questions for her?
Sure. It says, where are you in recruitment for Part B recruitment out of the 100 patients?
The part B, we need a total 150. Now we have 70. No, I think part B we just started. And
we're
total,
to 29 patients for Part B.
Yeah,
So
29
yeah.
Part B. The total we have 72 patients enrolled. Yeah.
Perfect.
So,
and then what does primary completion of May 2026 mean? Does the treatment end even if the treatment is proving successful for the patient?
You mean the treatment duration? Is this
So the question is, what does the primary completion of May 2026 mean? Does it mean that treatment ends then?
No, the patients, if it's still ongoing for the treatment, we can put patients in our rollover study. That's what we did for our phase 2 as well. But the completion of the study just mean our primary analysis may occur at that time.
Okay, perfect. There was a question if this particular inhibitor is used for any KRAS mutation patients.
The coexisting mutations have been occurred during our recently the biomarker analysis in our phase 2 data. So we do not exclude patients with other coexisting mutations unless these patients had FGFR fusion and rearrangement. So this is the absolutely inclusion criteria we need.
Okay, perfect.
Lourdes, I see another list of questions. Sorry, I didn't go through them. Yeah, please.
That's okay. So there was a question about when referring to FGFR mutation, aka non-fusion, is this still referred to as a point mutation, or is verbiage still fairly known as interchangeable?
Yes, when you talk of FGFR mutation and non-fusion, it refers to a point mutation. And these mutations can be, so the FGFR gene has a kinase domain, like the business end of it. There's another extracellular domain, so it can occur anywhere along that pathway. But mutation would be a point mutation for which there is no approved drug right now. So this drug is showing activity over there and also was seen with futibatinib to some extent. So this drug is showing activity, and hopefully this may be an option for those patients.
Do you know yet if certain fusions like the BICC2 versus other fusions are more receptive to FGFR inhibitors in this trial?
No, I think they are all effective. I mean, it seems to work against all fusion. And there are so many, I want to explain that FGFR2 rearrangement often refers to a fusion whose fusion partner is not known. And it was effective against those rearrangements as well. So far we have no evidence to believe that BIC1 or works better than others or so on. They all seem to have equal degree of benefit from the drug.
And then when you say FGFR, does that include FGFR2? Yes. Okay.
Yes, definitely. Yeah.
How long is Tinengotinib effective for before the cancer starts growing again?
So it really varies. So progression-free survival refers to how long the patient is doing well before the cancer progresses. So in this, you're right, it's 6 to 8 months is the average, but it's a bell-shaped curve. So some people could be less than that, some people could be more than that. I've had patients do well on this sort of drug for, close to 2 years. So, but that's the average, what you're seeing 6 to 8 months.
Does Tinengotinib have any implication or application to the FGFR4 amplification?
We don't know that to be the case. So far, it's point mutations I haven't seen any FGFR4 amplification on this. Dr. Fan, is that correct?
Yes, correct. Mostly targeted for FGFR 1, 2, 3. Yeah.
Okay. Can you explain why would patients not be eligible if patients had previously been treated with 2 FGFR drugs?
This is just based on our phase 2 data, phase 1 data. That's how we have sorted out. Maybe we have only patients with one prior FGFR inhibitor will be more effective.
Yeah, so Lisa, I want to point out that I've done many FGFR trials, and when you give more and more drugs, sometimes the pattern of mutations after multiple FGFR inhibitors is different. They may get, for instance, not an FGFR mutation like N549, etc., but they may get a KRAS mutation or an NRAS mutation. And for that alone, without FGFR, this drug will not work. So as Dr. Fan mentioned, we have seen activity after one FGFR inhibitor. And we don't want to challenge the system by trying to go to many, but hopefully we will learn with time. If this drug does get approved, we can investigate. I don't want to forget my friend, who is, I assume, are similar to pemigatinib and furibatinib. So Fred, has a different type of toxicity. So pemigatinib and furibatinib, they're with nail changes, hand changes, eye changes. You know, this drug is a little different in the sense what patients can get high blood pressure. They can get some hand changes, but to a lesser extent, they can get some mouth sores and diarrhea. So it's a slightly different spectrum than some of these drugs. You don't get like a high phosphate and that kind of thing.
Can you share again when the clinical trial will be done?
When will be done? You mean this phase 3 study?
Yes.
Is the
When will it be concluded?
Oh yeah, the primary completion is next June, 2026 June.
Okay, perfect.
That's estimated, yeah.
And you may not be able to answer this question, but with Tinengotinib, do you have an idea when this particular medication would be available as a prescription for patients versus in the clinical trial?
That will depend on the results. If next June we have the primary analysis showing the positive study, we are applying for NDA, but we are prepared for that as well meantime.
Okay. Is it possible for you to show the site map with the clinical trials again, just on the screen so people can see it?
The size of the clinical trials, yes.
Yes, please.
Sure, yes. And all those information you also can find in clinicaltrial.gov. We have all the sites listed there and the contact information of each site. Yeah.
Okay. Can these inhibitors be used for CHEK2 mutations?
Yes.
So, Porter, how often do we detect FGFR2 in ctDNA, that is circulating tumor, versus the tissue? Well, I mean, the sensitivity of circulating DNA is lower, so it's less likely than what we find in the tissue. But we have found actually the blood test post, like at the time of resistance when we do a liquid biopsy, to be quite revealing. Most of the time, you do get some information in that biopsy. Dr. Fan, do you have any actual figures for after progression, like what percentage or UAKD node did we find a positive liquid biopsy?
We do have from our phase 2, that's we are working on the phase 2. We have thorough analysis for biomarker based on the dynamic changes of the mutations. Yeah, after PD or after PR, and also off treatment, all the dynamic changes. So that is still in the we are exploratory objective from our phase 2, phase 1, and we also have the large phase 1 study we just completed. We are also working on those patients' biomarker data and to conclude what's the exactly the chance and of the biomarker to impact on the study effect. Yeah.
Perfect. Could you speak to any risks or benefits of Tinengotinib as a first-line treatment rather than waiting until the pemufuribatinib stops working, as it seems it works with more mutations?
Sorry, Lourdes, I'm trying to see what the question is.
It is the second one on the Q&A list by Cindy.
Second line of the Q&A. Okay. Well, I'm sorry, I can't find the question, but can you repeat it? You said when...
Sure. Could you speak to any risks or benefits of tinengotinib as a first-line treatment rather than waiting until the pemi or futibatinib
Got it.
stops
Will
working?
you use tinengotinib as a first-line treatment, like a first-line FGFR inhibitor instead of resistance? Well, it's intriguing. I mean, we certainly once, hopefully, the drug is approved or after the phase 3 is done, that will be an avenue one can explore either alone or in combination. But right now, that's not how it's being developed. It's being developed right now in the FGFR refractory space, and we'll see how that result is and fall before going further.
Do you think we will start seeing even more trials for FGFR inhibitors, targeted treatment plus chemo and/or immunotherapy? All in all, is this a direction we could be headed?
Yeah, definitely. I think we do need combination because these drugs work, but they work for a limited time. And so we have to, actually this tinengotinib is a good example of combination strategy because it doesn't not just inhibits an FGFR pathway, but also inhibits VEGF pathway, the vascular factor. Makes sense to add immunotherapy on top of that. And a trial of this nature has been done in China, which with a small experience, which shows incremental effects. As you know, we are trying to do it at many centers, but that's certainly the next frontier, how we can combine it, particularly with immunotherapy. Because I do believe that VEGF effect will synergize with immunotherapy and we will get a better outcome. But I also want to point out of all the cholangiocarcinomas that we have profiled, FGFR altered cholangiocarcinoma has very few immune cells. It's kind of what we regard as an immune depleted tumor. So whether immunotherapy will have an effect on it, we don't know. We'll have to find out.
Okay. And then if someone wants to get into contact regarding the clinical trial, the best way, Dr. Fan, to do so is through the clinicaltrials.gov site and connecting with Transthera or through the site themselves to find out more about the compassionate use, if there's any financial assistance involved or available for patients.
Yes, please contact us directly.
Perfect.
So yeah, I see some other questions as well. You know, the folks at Princess Margaret know this trial well, and I think it was not opened in Canada because there was no pemigatinib approved there, you know, so this is like a post-pemigatinib or futibatinib trial, and there was nothing approved at that point. All the patients were getting it. That's the reason why this wasn't open there. But that may change. Plus, I'm glad you're in Toronto, so Buffalo is not so far, and it is there. It is open there.
For someone who's been on pemigatinib for about a year and is doing well, would they qualify for this trial, or would you recommend that they stick to pemigatinib?
Definitely, if the pemigatinib, I mean, worked for a long period of time, you know, these are the patients who responded the best in our phase 2, patients whose tumors originally responded and then progressed later on. These patients did do well, so I would recommend considering the trial in that case.
Okay. It looks like the University of Kansas trial site is listed as being in California. Is that correct?
Go ahead, Dr. Fan. I don't know specifically what university.
No, it's not. It's in Kansas. That's an error. I'm sorry about that.
No,
We'll do a double check. Thank you for bringing that to our attention.
perfect. Thank you. Is 10 reflecting overcome resistance in patients who have been on more than one previous FGFR inhibitor in the trials?
Yeah, this will be excluded from this clinical trial, but the patients can apply for the compassionate use, like a single IND.
Okay, thank you.
So, Melissa, I think clinicaltrials.gov is a good place to go for the trial. And Katie, I don't know if patients over here can contact you in some way.
Yes. So hi, I'm Katie. I'm the clinical project manager with Transthera, and I'm overseeing this trial as well as our other Tinengotinib trials. You can always feel free to contact me. I know that CCF has my contact information, and they know that I can be the main point of contact for anyone asking. So, and I believe I'm also on clinicaltrials.gov as a contact. But if not, it comes directly to our team. We have a pretty close team and we all work together. So everything will ultimately come to me anyway. But yes, you can feel free to reach out to me anytime. And like I said, CCF has my contact information and I'll put my email in the chat in case anyone wants to take it down.
Yeah, and the same goes for you, Jeff. Katie's a wonderful guy, and I'm sorry, wonderful person, and I think she's the one you can contact. Yeah, for the question that you posed.
Perfect. Thank you. Can you explain what the mechanisms of TINN is different versus irreversible FGFR inhibitors like futibatinib?
So the mechanism of Tinengotinib is different from the mechanism of the irreversible inhibitor. Is that what the question is, Lourdes?
Yes.
Yeah. So, Tinengotinib targets in a different way. I mean, like the pocket that I showed, most of these inhibitors target that pocket. So it targets in a different way, so it doesn't hit the mutation. Plus, it targets other pathways. The main other pathway that is being targeted is called VEGF, where it prevents the cancer from spreading along blood vessels. So I would look at it like that it targets different pathways, it targets away from the main binding pocket. So it's a different mechanism of action.
Okay, thank you. I know we have a lot of questions about KRAS mutations, and I know this is a specific webinar for FGFR, and hopefully we will have...
This is not a KRAS inhibitor. This is not a trial targeted for KRAS. But like Dr. Fan mentioned, if patient has an associated mutation with FGFR2 fusion, that's fine. Those patients will be included on the trial. They will not be excluded. It is uncommon, I've known by experience, to have KRAS along with FGFR2 fusion. But if it is present, they can still be candidates for the trial.
Thank you. That's perfect. I think we got all of the questions. Thank you both so much for presenting today and sharing this information with the community. I appreciate it. Thank you everyone who was on the webinar today. We appreciate all your questions.
Thank you all. It was very good to see you. And thank you very much, Lourdes, for organizing this.
You're welcome. Everyone take care.
Thank you. I also want to thank all the patients, families who are participating in our clinical trial, and their contribution are helping us understanding more and develop the new treatment for cholangiocarcinoma patients.
Thank you, Dr. Fan.